Thank you very much. Yeah, so hi everyone. I'm Navin. I'm an emergency medicine registrar, which means I'm a doctor that works in A&E, and that's my formal training program. I'm also a Leicester graduate as well, and I graduated from Newcastle just before that. And as has been said, I was asked last year to do a talk about the working during the pandemic. Obviously, last year um, things were a bit different to now. And we'd all been in this pandemic by that point for about 6 months, and I was working in intensive care at the time. 12 months have passed since then, and we've had multiple waves since then, including the rollout of a vaccine. So I've updated this talk to include a bit more. Um, I will every now and then I'll have a look at the Q&A section to see what questions there are. I haven't got it open in front of me all the time because it covers quite a large portion of my slides, but every few slides I'll have a look at it and try and answer a few things. Otherwise I'll leave them till the end, and then I can answer them all there. But hopefully this will be an enjoyable talk. Can I just check that people can see my slides at the moment? Yeah, cool. Awesome. Right then. So whilst I do this talk, it's important to have a think about what's training like after medical school. How would you feel if you're working in a situation nobody's ever been in? So a pandemic, there's no working healthcare professionals that have ever been in a pandemic before. The last one was Spanish flu back in 1918. I'd be impressed if there was a healthcare professional, and a little bit worried if there was a healthcare professional still alive today that's still working, having worked in that pandemic. Also have a think about which professionals are involved during my talk as well, and how did we adapt to an ever-changing environment. Also have a think about how you cope with stress, and everyone's different, so you'll have different ways of coping with it, but it's important to reflect as well, and also think about how important reflection actually is, not just about stress, but about everything that you do day to day. So that's a few things to think about. So last year, as I said, I only had to do a talk on the past 6-ish months. But now it's been a year since then, so I'm having to talk about the last 18 months instead. So what I've done is I've divided it into three. So I've divided it into the first wave, which is a very condensed version of last year's talk. Then I've added on the winter wave when I've been in Leicester Royal Infirmary in the emergency department, and then sort of the recovery, I suppose you could call it, or the easing of restrictions, I think is a better way of putting it. And I've been in Leicester Royal Infirmary, both in children's and adults emergency department as well. So that first portion, I'll talk about how things were escalating, and how I was redeployed to intensive care, then rotated through to emergency department as an emergency medicine registrar, and then through the children's A&E and still working in adults A&E up till today. So just to give you a little catch up of where I was at the time of the pandemic actually hitting. So I graduated medical school in 2016. I did my foundation training, so that's the first 2 years of being a doctor. All doctors who graduate have to do foundation training. And so you do that for 2 years. So I did it in University Hospital Leicester. And one of my jobs was at Bridge Street Medical Practice as well, which is in Loughborough. And so that rounded off the 2 years of foundation training. I then got a job as an emergency medicine trainee. So I started that in Northampton General Hospital in the East Midlands Deanery. So I did 6 months of emergency medicine. Then I went to anaesthetics, because we all have to do 6 months of anaesthetics if we want to be A&E doctors. So I did 6 months there from February 2019 to August 2019. And then I did I started a parallel training program in academia, so medical education, which is why I do a bit of stuff with the University of Leicester. And from August 2019, I continued my clinical training. So that was 6 months of intensive care medicine. This was before the pandemic hit, so I was meant to be there. And then whilst we were doing these 6 months, there were mentions of this outbreak in China, but we didn't really think anything of it. It was very much like the mentions of the Ebola outbreak in Africa when I was still a medical student. we trusted the world governments to keep it under control. And then January 29th, 2020, with the first confirmed case, according to the news, in the UK. And then February 5th, 2020, I rotated from intensive care to acute medicine, still at Northampton General. But that's when things started to escalate a bit. So let's just have a look at the Q&A. How does it feel having such an important role? I'll answer that at the end. Since you've gone through an actual pandemic, what's some advice you'd give to us aspiring medics? I'll answer that one at the end as well. But these are very good questions, and I promise you I will answer these. Okay, so February 2020, I'm working in acute medicine. My plan is I've got 6 months of acute medicine, then I rotate to Leicester Royal Infirmary as a registrar in emergency medicine. That's what's going through my mind. And there's this pandemic that we're hoping won't get out of control. How wrong we were. So whilst I was on acute medicine, the hospital had a few ideas of how to do things whilst things were going on. So firstly, we weren't massively encouraged early on to consider COVID-19 as a differential diagnosis. So that's what DDX stands for. Differential diagnosis is where you're seeing a patient who's come to the hospital, and you have to think based on what your questions are, what the answers they give you are, what you find on your examinations, and what you find in your investigation, so your blood tests, your scans, so on. And you come up with a list of possible diagnoses. And as you do more investigations and as you ask more questions, that list gets shorter and shorter and shorter. And COVID-19 wasn't really encouraged early on as a differential diagnosis. We didn't know much about it, just what we've been told about things going on in the Far East. But we didn't know a huge amount about it at all. In the emergency department, so the A&E and intensive care, they'd begun training exercises. So this is a photo of the team doing training. So this is the anaesthetics team, because the plans were that the anaesthetics and theatre staff were going to be deployed to intensive care in the event of a massive surge of cases. So they were all doing training on how to intubate COVID patients whilst keeping themselves safe. And also the plan was that theatres was going to be converted into an intensive care in the case of a massive surge of cases. And the anaesthetic team were having to learn how to do intensive ventilations with the anaesthetic machines, which is quite complicated. The current practice, when paramedics have a patient that they think could be COVID positive, they have to call the A&E department, and that way the patient can be isolated on arrival to prevent outbreak within the emergency department. People who are feeling unwell but can get to A&E under their own power, in other words, we call those walk-ins, they go straight to an isolation pod, which is, well, in Northampton, it was opposite the A&E department. And there's a phone there and a camera there. And that way they can be assessed remotely before being seen in a side room by a doctor. So again, this is to protect other patients in the A&E department from being exposed to this virus. In the meantime, on the medical wards, all the side rooms were being cleared out of patients. So all patients that were in side rooms were either being, if safe to do so, discharged home or sent to step down wards, or moved to a different ward or a different area of a ward, so that all the side rooms could be emptied, so that we could put COVID-19 patients in there. Because side rooms are, they're as they sound. They're a room off to the side where there's double doors, so they are completely isolated from open bays, where you'll have multiple patients. And side rooms can only contain one patient. So that was the plan. But otherwise, we were carrying on. You know, at this point, we weren't wearing masks. I mean, looking at this photo, it's been 18 months, and I can't remember the last time I saw this many healthcare professionals in a room without any masks at all. You know, this is really blast from the past for me. So it's interesting to look at this far down the line. And then suddenly cases started to rise. Then it became a bit of a problem. So preparation wise, we were kind of preparing as cases were rising. So various areas were repurposed. So you can see on the left, I've got a picture which says main theatre staff only. That is the doors to the theatres. However, that was repurposed. So all elective, so that is planned operations, were stopped. And emergency operations continued only. It was only emergency operations. The rest of the operations were stopped so that we could repurpose all the theatres to be intensive care beds. And each theatre could hold up to 3 patients because we could fit 3 ventilators in there, and we could equally space them out so that we could still get around them and still provide intensive care. On the right, top right, you've got here an open bay being converted into an isolation bay. So that way we could cohort patients together without infecting other people in different bays. So they were building temporary walls and doors. And then in the meantime, you've got in the bottom right-hand corner, the public seemed to be going crazy by buying pasta and toilet roll, which to this day, there's been no trial that has proven that toilet roll stops you from getting COVID-19. So, you know, I still don't really see what the pull was for people getting toilet roll, but you know, each to their own, I suppose. Mask fit testing was done across the hospital as well. So we had to be fitted for these tight fitting masks, which did mean that seeing as I worked in a district general hospital, so it's out of the city in a different area, many of us, well, the hospital couldn't afford to get the big hoods that cover your entire face. So many of us who had facial hair had to actually shave it off. The only reason I'm starting to regrow mine is because I'm on annual leave. But otherwise I keep a clean shaven look to make sure that I've got a tight fitting seal around my mask to protect myself, basically. As doctors, we still do exams after we graduate. They're called postgraduate exams, and those exams are actually cancelled. So all Royal Colleges cancelled their exams. I was lucky, I actually sat mine a week before they cancelled them. So I got mine in before they were cancelled, but other people were not so lucky. And this is mainly because obviously you've got, say, 1,000 doctors sat in a room, all who are exposed to COVID-19, patients suspected and positive. What you don't want is one person coming to the exam who ends up having COVID and spreading it to 1,000 doctors who have come from all over the country and then carry their infections back to different parts of the country, and suddenly it becomes out of control. So that's why they cancelled them. Non-essential hospital staff were sent home, so they tended to be the admin staff who worked in the offices because they didn't need to be in hospital and there was a risk to them. And then shielding started as well. Then we went into lockdown as well. Memory serves, I think it was March 2020, sometime in March. And just before we went into lockdown, a colleague and I were approached about being redeployed to intensive care. I was very up for going back because I wanted to do my bit, and I know that it's quite difficult to get doctors who have intensive care experience in intensive care, so I was very happy to go. My colleague was a bit more worried. He had a family, he had children as well, so I completely understood. Both of us were from the BAME ethnicity background, so we were both at risk, but at the time we didn't know that that was a risk. So we had no idea. But till we were redeployed, we were carrying on in acute medicine. These sorts of comments were being made from other staff. Patients would panic. It was as if we were giving them the death sentence when we were saying, we're going to have to test you because we think you might have COVID-19. So remember, at the time, we were only testing, early on, we were only testing suspected cases. It then became we were testing all admissions, and that was fairly quick that became a thing. Then we started testing hospital staff a few months later. So it was all a bit different back then. So when you think about why patients panic, think about what was being said in the news a year ago, well, a year and a half ago. All the news were saying were how many deaths there were in China, how many deaths there were in Russia, how many deaths there were in America, and how many deaths we were having in the UK. They weren't really talking about the survivors. They weren't really talking about the good stuff, and that's what the news does. That's standard, really. But it meant that patients were really panicking when the minute you said, I mean, people were having absolute breakdowns in their rooms. They were getting aggressive. Some of them were getting incredibly emotional. It was really difficult at times, and we just had to maintain professionalism throughout. So yeah, the pandemic continued to escalate, and what was great was that the general public really appreciated what we were doing. And I know that there are jokes about, oh, you know, can't pay our bills with claps. But to be fair, I thought that the claps every Thursday in the evening, I was really touched by it. It was really nice to go home and be driving along the streets, and you'd have people out clapping, applauding us. Or if I was already at home, I'd just open the window and there would be huge cheers and claps. It was really nice. But it wasn't just doctors, it wasn't just hospital staff, it was also the paramedics going out to get the patients. They were putting themselves in direct contact at risk. And then don't forget the support staff as well, the domestics who would come in and clean the rooms before the next patient came in. So they were at huge amounts of risk. The porters, who were pushing patients around, getting them from A to B, who were in direct contact, they were at massive risk as well. So don't forget them. For us, policies were changing daily. To begin with, they were twice a day. So it was really difficult to keep on top of what we were supposed to be doing and when. It was like, I don't know, I think it was maybe halfway through April or late April, suddenly the policy changed and we had to wear masks at all times. And up till that point, we weren't wearing masks when we were away from patients, only when we were near patients. You know, we were having to wear certain types of masks for certain patients and different types of masks for different patients. Then it all became the same type of mask. Then it changed back, and it was very back and forth. Clinical assistants were employed, so those are medical students who were employed to help out on the wards. They really stepped up and helped us out. That was very kind of them. They didn't have to, it was purely voluntary, but they were paid for it as well. But we were very much learning as we went along, and we still didn't really know what we were doing. As evidence was coming out as and when, and we were doing our best to stay up to date. But realistically, our main goal was to keep people alive until they could fight off the virus. So anyway, I got redeployed. I got redeployed I was told on the last day of March that I was going to be back in ITU. I was given less than 24 hours notice. And I was told that my ward team were going to be informed, and I didn't have to worry about talking to them. Everything was going to be sorted out for me. I just had to turn up in ITU at 8 o'clock the next day. So I think I was told at 1 o'clock in the afternoon. So I was given less than 24 hours notice to get in, or less than 12. No, more than 12 hours notice. But I wasn't given long. And it was very different on ITU. You know, I'd only been away from ITU for just over a month, and everything had changed. You know, walk in, I had to be retrained on how to get all the PPE on, where to put it on, how I take it off, where I take it off. And all the patients were like nothing I'd ever dealt with. Well, nothing anyone had ever dealt with. But this first picture, top left picture with all of us in red. So I'm the one crouching down. We took this photo because we thought we looked a bit like a boy band. But we were split into teams so that we could reduce the contact with each other. There were a lot of us on ITU, but we were put in teams of 6, and those 6 people would work the same shifts until the pandemic was over. So you had to really get on with each other because we would only see those 6 people. And it also allowed us to take a bit of time off, or if there was a requirement to self-isolate, then it meant that there was still quite a few of us on. We were having our annual leave cancelled. It was all rejected at the time because we're dealing with a state of national emergency. I've put on the left here a kind of journey for a patient of what it's like. to actually go into hospital if you have COVID. So you can either come into A&E, well, everyone comes into A&E. You can either be admitted to the ward. If you don't need intensive care, you just get managed on the ward. Some patients come to A&E and they immediately need intensive care. So the intensive care team, that included myself, we would come down to the patient dressed in all our kit. We would do a very complicated intubation, and the people that were intubating the patient would remain in the room. They would make sure that the patient was on the ventilator, a portable ventilator, and we would put a plastic sheet over the patient, almost making them in an airtight seal. We would then push the patient through the doors of the room that we'd intubated them in, where there would be another 2 people from intensive care. They were called the clean team. And they would catch the patient on the bed and they would take them up to ITU, take them straight into intensive care. In the meantime, the 2 of us that had just intubated the patient, we would stay in the room until the aerosol would settle to the ground. That takes about 20 minutes, after which we would clean the room ourselves. And we would take off all our kit and we would walk out the room. That way we would not put domestic staff at risk. It was a very complicated and time-consuming procedure, but it was to ensure patient safety and also staff safety. You can see on the right here, I went into the city centre because I was going to give blood during the pandemic. I had to see it for myself as well. I needed to see what lockdown actually looked like. And this is the middle of the day. So you can see on the clock, 2 o'clock in the afternoon on a Saturday, would you believe? This is the clock tower on a Saturday. It is empty. I was shocked. I just couldn't believe it. It was amazing. And in the bottom here, you can see I'm in the full PPE. Those masks, by the way, are incredibly painful to wear. We eventually got used to it, but we were developing pressure sores. The condensation on the inside of that mask was insane. And we would wear these for hours at a time. We couldn't just step out to go to the toilet because you had to take everything off. So it had to be a very carefully planned procedure if we wanted to step out. And patients were incredibly unstable whilst they were on these machines. So a lot of us had to stay in for hours at a time. I think the longest I stayed in was 8 hours without a break. I was very dehydrated. I was bursting for the toilet and my face was in a lot of pain as well, especially the bridge of the nose. So that is me at the bottom. That's actually me down in the theatres, the operating theatres. So you can see there an anaesthetic machine behind me that is hooked up to a patient. So we'd overflowed into theatres because we had a surge of patient that the intensive care couldn't cope with. So we had to overflow into the operating theatres as well. So we hit May. Just before I talk about May, let me have a look at what the questions are. So have you had to make particularly difficult decisions such as triaging patients for ventilator or life-saving treatment? How do you utilise NHS values and ethics? So I'll answer that now. Yes, I did have to make difficult decisions. It is not just me that made the decision, so it's a team decision. And there were people that we were not able to facilitate ventilation for. That was a calculated decision based on the abilities of the patient before they came in, also the list of conditions that they had, and the chances they had of survival as well. So not everyone can survive on a ventilator. If you were to say that COVID didn't exist, that still applies as well. So not everyone can survive on a ventilator. It's a very intensive care is very much the clues in the name. It is intensive care. We are effectively beating up a patient by putting them on machines that is unnatural to try and help them to get through whatever it is they've got wrong with them. And not everyone can do it. So older people with lots of problems, their bodies are already at suboptimal function. So for those people, sometimes intensive care is actually detrimental to them. It can be harmful to them. So it is within their best interest sometimes to not be admitted to intensive care and actually instead to pass away with dignity on the wards instead, or even be sent home to pass away. So what do you mean by acute medicine? So when a patient gets admitted through A&E, they then go to the acute medical wards where they get seen by the acute medical team. And the acute medical team can either sort them out quickly and perhaps discharge them home, or admit them to a parent ward, a ward where there's a more established team. So it's like another level of a patient journey. I'll come back to the questions in a minute. So let's talk about May 2020. So now these sorts of stickers were being put up around the hospital, and it kind of sinks in that this isn't going away anytime soon. We're more used to it now. It's unfortunate that we became used to the numbers of deaths that we were having to deal with, and the conversations we were having to have. National and local policies, they're changing much less often. So rather than twice a day or daily, they're more like weekly. And sometimes they don't change for a number of weeks. So it's a lot easier to keep up to date with. Families were banned from the hospital. So before you could have visitors, you can't anymore. And that is still the case, unfortunately. Although there are some special circumstances, families were banned from the hospital at this point. So we were having to update them over the phone, and that was incredibly difficult to do emotionally, because you often have to say the same things to all these families. Remember, intensive care, to be on intensive care, you have to be pretty damn unwell. When I say really that unwell, you're fighting for your life, and the chance of you surviving already are pretty slim if you're being admitted to intensive care. And with COVID, the chances were even slimmer. Honestly, we couldn't predict who was going to survive and who wasn't going to survive. So often our conversations with the family were very, very negative. They were very difficult, very pessimistic. Evidence started to come out that BAME were at risk, which obviously was quite scary to hear about. Although I was working in Northampton, I lived in Leicester. So I would drive quite a distance to get home. And when I get to Leicester, and even driving through Northampton, it was very, very upsetting to see people openly breaking lockdown rules, because that, a lot of people were fine. They'd catch COVID and they would be fine. And that's great for them. But what people have to remember is that if you catch it, you can pass it on to a lot of people, and those people may not be fine, or those people's families may not be fine. And I think a lot of people didn't think about it like that. So it was really sad to see people breaking lockdown rules, and it was frustrating for us as well, because we were following them to the letter, and then we were seeing the ramifications of people breaking lockdown rules. But luckily, thankfully, in May and June and July, things really started to calm down. The numbers were really dropping. We were much more prepared for things as well. So we were managing the patients much better. A lot of research had gone into COVID by this point. So we had certain drugs that we could give that would help survival rates, that would reduce hospital admissions and improve outcomes. And we were giving those very, very effectively. But on the other hand, because a lot of people were really taking it very seriously in the public and were not coming to hospital if they didn't need to. But it meant that some people who were, so kind in trying to protect others, but they were coming in late, with sepsis, with strokes, with heart attacks. They were coming in a good couple of days later than they should have done, or a good couple of hours later than they should have done. And that was really sad, because they had tried their best to protect other people by not coming into hospital, or try their best to not come into hospital because they thought maybe it's nothing, or they didn't want to catch COVID because you could easily catch COVID in hospital. But it meant that people were coming in later than they should have done, which was really sad to see as well. This was a very common phrase that we were using over the phone. I'm sorry to be the one who was telling you this, but, and it's often how I would start my conversations with family members on the phone, talking to them about their loved ones who were in hospital, because we were really sorry to tell them, but it was never anything positive. It was very rarely positive stuff that we would say. Let me just have a look at the questions. Like I say, I'll probably answer most of them at the end. How is working as a doctor or training differ prior and during COVID? That's quite a complicated question, so I'll have to answer that one at the end, actually, because it's changed a lot. How did you cope with the pressure during the pandemic? That's a really good question. So firstly, I got on really well with the team that I was working with. So we were quite lucky. We all got on really well together. And a number of us still work together now in Leicester. We all stay in touch, so it made work a lot easier. The department was very, very helpful with us. So we did 4 shifts on, 4 shifts off. So that 4 shifts off was a nice break. I mean, couldn't really do much, but Netflix and Amazon Prime, Disney Plus wasn't a thing back then. Apple TV, they were very helpful. I gotta say, and no, I don't work for Netflix or Amazon or Apple, but they were very helpful. So I binge watched a lot of stuff, did a lot of home workouts. So exercise helped, and just having someone at home with you really helped. I do feel for the people that lived alone as well. That helped a lot to cope with the pressure and the stress as well. Anyway, let's get back to the talk for the moment. So anyway, yeah, in August, all doctors tend to rotate in August, and I was no different. I had to progress in my training, and luckily I was able to progress despite this pandemic because I was so on top of things up to that point. So I came to Leicester Royal Infirmary, and I was going to work in the emergency department because I'm an emergency medicine trainee, and this is where I was going to be now for the rest of my training. So Leicester had established their policies because we were 6 months into the pandemic. So the induction to the department included PPE rules. They also talked to us how they redesigned the department to have a COVID area and a non-COVID area, and what we had to wear in the COVID area, what we had to wear in the non-COVID area, and how it worked with admission to intensive care, what therapies we could give, what COVID-19 therapies we could give, and we just generally better understood our enemy of COVID-19. We had a much better understanding. But obviously, in August, most of the country had come out of lockdown, but Leicester hadn't, which was something that everyone kind of forgets. Is July 19th was actually the first time Leicester fully came out of lockdown. I don't know if anyone's realised this already, but that was the first time, July 19th, 2021, since the beginning of the pandemic, that's the first time Leicester as a city came out of lockdown. So Leicester was still partially in lockdown in August. And annoyingly, variants were starting to emerge across the globe, and also in the country. And this was very sad for us to hear because we'd been working non-stop. And then we started to realize, oh, variants are now going to replicate out of control, spread out of control, and we're just going to stay in lockdown for the rest of our lives at this rate, aren't we? And unfortunately, winter came at the same time as the Kent variant. There was no way of preparing for the Kent variant. The way that it swept the NHS. It certainly swept Leicester. It was like nothing we could have expected, really. So this is a picture of me in A&E, the emergency room. This is where the sickest patients come to. So here I am wearing my full PPE because that's what we had to wear in the emergency room. And that's because everyone was suspected to be COVID. And to be honest, during winter, probably about 95% of patients were COVID positive or suspected COVID. It was really difficult because the Kent variant was more deadly as well as more infectious. And so we were seeing younger patients in a much more critical position. Up until that point, up until the Kent variant came, things were really quite calm in A&E. They weren't too bad. Like, there were busy days, don't get me wrong. And now that people were starting to come to hospital more because things were easing, we were getting a lot of stuff. But then COVID numbers just suddenly skyrocketed when the Kent variant swept the country. And then we started to go towards lockdown again. But I think things were a bit too late by then. It really was non-stop COVID over winter. I've got to say, looking back at it, and at the time feeling this way, I wouldn't ever really want to go back into that sort of situation. It was really difficult personally, And I think all my colleagues would agree on that. It was tough conditions working. The shifts were incredibly intense. You would have patients being brought in who were already ventilated by the paramedics, or patients that we had to sedate and ventilate in A&E. Intensive care, they basically lived down in A&E. They would come down, they would collect a patient, take them up, then they would come straight back down, get the next patient. Intensive care became overrun in Leicester. A&E became overrun. Like we were just really struggling. We were having to make quick decisions. And for me, it really hit me hard when I still remember I was looking after this guy. So I'm 32 years old. In winter, I was 31. And this guy came in, 31 years old, born in the same month as me. And he was about to be intubated. And I was going to be the one who was telling him this. And it was, you know, he was a young, fit, healthy guy. And it was like talking to myself. You know, I was saying to him, I'm really sorry, but we're at the point now, we're going to have to intubate you. And the look of fear on his face. And for me, the thought just crossed my mind, I could be the last face he ever sees. And this is the face that he would see, that you could see on the picture of this. He couldn't even see my smile, you know, not that I would be smiling at him, but he couldn't see my facial expressions. He couldn't really read my body language because I was wearing this thick PPE. And that was really difficult to process. And I, you know, that was for me personally, but I mean, it must have been horrendous for him. And honestly, I don't know if he survived, and I didn't chase it up really. I didn't really want to, in case the worst had happened to him, and that would have been really demoralizing for myself. So, but I hope he did survive. But yeah, younger patients really were coming in. And again, much like the first wave, we were facing our own mortality. The worry, the ever-present worry that we could catch it, that we could become critically unwell, and that we could die. And this was all because of it spreading uncontrollably throughout the country. So we went back into lockdown again. It was announced over the Christmas period. Christmas was cancelled for Londoners, which was very sad. And then we went back into full lockdown again. And we had to do what we could again. So it was all very much again, you know. For many, you know, we did what we could, but it just wasn't enough again. And it was worse than things were in the first wave, I gotta say. It was tough. And it's always weighed on our minds, I suppose. But there was light at the end of the tunnel. The vaccine had come out. And I was one of the first people to be vaccinated. I was vaccinated very early on. So I think it was towards the end of December. I got my first shot. So this is a picture of me getting my second dose of the vaccine. I was originally going to get my second dose something like, what was it, a month or 2 months down the line, but then they changed that to 3 months so that more people could get their first dose. But I was happy that we had a vaccine coming out, and I was still apprehensive. I was still worried that we were going to put all our eggs in the vaccine basket, and all you need is one variant that's resistant to the vaccine, and suddenly we're back to square one. But you got to do what you can, and you got to leave things to people who are paid more to deal with that stuff. And honestly, I wouldn't want to do their jobs. I wouldn't want to be the Prime Minister. You can criticise him all you want, but he had no one that he could talk to. The government had no one that they could talk to ask for advice on this, who have dealt with a pandemic before, because no one has. So we did what we could with the cards that we were dealt. But as lockdown started to ease and numbers started to go down again, suddenly everyone was coming to A&E. And although we had this winter wave, and you hear about winter pressures before the pandemic, we are currently dealing with a winter pressure number of patients in the emergency department. And yeah, Leicester ED was no different to any other ED across the country. We were breaking records all over the place. And then came the post-vaccination complications. So quite rightly, a lot of people who had headaches, having had the vaccine, came to A&E. But I can reassure you that the complication was incredibly rare. But yes, there were complications with the vaccine. But everyone who had a headache was coming to A&E, and probably about 99% or something at the time did not have anything wrong with them. But yes, there were complications. And because the GP surgeries were really struggling as well, because a lot of people were now, they put off seeing doctors because they didn't want to come to hospital, they didn't want to see their GPs for various ailments that were chronic, and they were then ringing in to the GPs, and the GPs were doing things over the phone, but they couldn't see everyone, they couldn't consult with everyone, and although they were having these phone consultations, if they were worried, they had to bring someone in, and they often had run out of time because they were trying their best to speak to and to see as many people as they could. And even they were struggling as well. So a lot of them were just saying, look, we can't see you. If it's a real problem, you need to go to A&E. That way you can be seen. And I completely understand their logic behind saying that. It makes total sense, and that's the safest thing to do for the patient. But it meant that we were getting overrun with all these things that didn't necessarily need to be in A&E. But you got to do what you got to do, don't you? COVID-19, it was still a problem. Don't get me wrong, we were still having the odd patient here and there through sort of April, May time. We were still having a few patients coming in that were COVID positive. They were very unwell, some were quite mild, some were moderate, and we were having to admit them. Some of them we were having to intubate and send up to intensive care. But we were in a much better position. And with the travel restrictions, variants were not really coming in from abroad. But there was this concern about the South Africa variant, the Brazil variant, and then the variant from India, and they all got renamed, but the India variant was the Delta variant. There was concerns of this Delta variant as well. And we started to approach Freedom Day, July 19th. And I'll just draw to a question that was asked earlier about the pressures, how we cope with the pressures, and how we all felt about it. It may come as no surprise that a number of my colleagues had to take a leave of absence due to burnout. A lot of people had to do that because we were non-stop. During a state of emergency, the hospitals retain the right to reject our annual leave requests, even though we're entitled to annual leave. And when the department is, well, Leicester A&E is the busiest A&E in the country, statistically, and we broke the European record twice in 1 week of number of patients coming to A&E in 24 hours. We were hitting 800 patients in a 24-hour period, twice in 1 week. That's how bad it got. And it's still pretty bad now. We're still hitting the 700s regularly in a 24-hour period. But obviously, a lot of people had to take a lot of time off. We were seeing a number of my colleagues coming in who used to be really bubbly, really happy, and they were just so upset. They were just not really talking, and you could tell that they were struggling. And sometimes you just have to realize it's okay to not be okay, and it's okay to just have to take time off. So a lot of them are now coming back refreshed. I'm off on annual leave, not due to sickness, but my annual leave couldn't have come at a better time. I had a number of friends, a number of colleagues saying, you know, you seem a bit more snappy, you seem a bit more negative than usual. And luckily my annual leave came at the right time for me. But Freedom Day for us, I don't know, everyone's got a different opinion on it. Freedom Day for the majority of people was, yes, we can go back to normal life. But we've got to remember, COVID doesn't disappear. It didn't disappear on the 19th of July. It's still there. And we were obviously having a rise in cases in the run up to July 19th, with the Delta variant spreading out of control in the UK. Luckily, it's not as severe, it's not as deadly, and the vaccine certainly seems to have helped reduce the number of admissions. to hospital and reduce the severity of the virus. So if you've had the vaccine, you're less likely, significantly less likely, to have a severe or critical infection from COVID-19. But for us, Freedom Day, it kind of meant, I don't know, I was a bit nervous about it because it just meant that people were probably going to go crazy, and they were going to go out, they were going to go get drunk, they were going to go mix, and then they were just going to spread the virus. And all it takes is one person to be harboring a new variant, and then that person can spread it, and then suddenly we're back to square one again. At the same time, though, because we've been working non-stop, for us, it was an opportunity to have a bit of normal life, even if it is going to be for a short period of time, or it could be for a really long period of time. I don't know. But it was like, for me, I was just looking forward to being able to go out for dinner, go to the cinema. I personally still wear a mask when I go, but I know a lot of people don't, and it's that relief of being able to take your mask off in a public place is also quite nice. But it meant different things to different people, really, July 19th. But that constant fear of, oh, are we going to get a new variant because now it's spreading so much? Oh, does that mean we can go back into lockdown? Could that mean that we're in lockdown over Christmas again? And I think a lot of people forget that. And so it meant burnout for a lot of people. But honestly, I'm still very optimistic about the whole situation. The only way that we can beat COVID-19 is together. And that's within the hospital and outside the hospital as well. So this is a picture on the right of, because obviously all educational stuff went backwards a bit, and then we restarted things, and had to keep things going. And the medical students, especially the student nurses, and all the allied health professional students, were absolutely fantastic. Like, they were coming in on placement, they were being very supportive, very appreciative. They were really helping as well. And I mean, from my opinion, they got a great experience, great training as a result. But this is us. We're filming some videos to show how to do things in an emergency. You can see a mannequin in the background. But really, what I also see here is you see different doctors and different nurses. So you got me at the front as an A&E doctor. To the right on the photo, there's Sophie. She's an emergency medicine doctor, and then just behind her is Javi. He's about to become a surgical trainee. Then you've got three nurses on the back row who all work in different areas of the hospital. Then on the far left, doctor-wise, that's an anaesthetist, and we're all trying to do this together. There is obviously a threat of another wave, but we can beat it together, and it is really important to stop the variants. But just remember that protecting yourself also protects other people. And that's the important thing. It may be a bit annoying to have to wear masks, to wash your hands every 2 seconds, to have to socially distance, but it's helping others as well as you from getting this virus. You may be safe, but other people may not be. But I am very optimistic about it. And honestly, even though it's been a tough 18 months, a long 18 months, from it, the things that I've gained, a huge amount of experience that I'm going to take forward with me through my career, a very unique experience, because I can proudly say that I've worked through and continue to work through a pandemic. I've overcome a lot. We have overcome a lot. I've made friends with people, stronger friendships than I could have ever imagined. That team of people that I worked with during the first wave on ITU, we regularly meet up for a drink when we can, because we've been through a lot together. And same in A&E, we've been through a lot together. It's brought us all closer. And the public have been very appreciative of the whole thing. For the most part, and I do feel for the families who have lost loved ones, and I feel for you if you are someone who's lost a loved one. But honestly, the support that we get from the people, even those who have lost loved ones, it makes it all worth it. It really does. And although when I started med school, I never thought we'd be dealing with a pandemic, It is what I signed up for. I did sign up for emergency care. I signed up for everything that comes under the NHS, and that includes dealing with global pandemics. So this is to just draw you back to what we talked about at the start, what you should be thinking about whilst I talk about all this stuff. Hopefully it gives you a better idea of answering these questions, and I hope you've gained a lot from this talk. I appreciate you listening to my talk as well. I thought I'd finish a little early for questions, but just before I do, as part of my job at the University of Leicester, I'm also doing research in medical education, and I've been allowed just to give you this slide. It's a study that I'm doing, and it requires your help, actually. It's for a focus group that we're hosting tomorrow virtually. You don't have to come anywhere. You don't have to put your cameras on. You don't have to have your microphone on. But you get a £10 Amazon voucher out of it that will get to you pretty quickly. But if you want more information, you can email that email at the bottom. But the focus group is tomorrow for 1 hour. So I'd really appreciate, because it would help me with my research, I'd really appreciate if you could sign up for it. I'll leave that on, and I'm going to look at the Q&As now, the questions. I'm going to go through them. So how does it feel having such an important role in the pandemic? Everyone that works in healthcare has an equally important role. So I don't feel like my role was any more important than anyone else's. I mean, it feels great to have done so much during a pandemic. But if I'm totally honest, actually, I extend the importance of roles to the general public as well. Everyone has an important role to play, and everyone who did abide by the rules and that were put in place, they did a huge amount to save lives. So everyone should appreciate what they've done. Did you ever feel like you were being thrown in without protection or any support? Yes, we did. So there were times where, Northampton General was really on top of things with the PPE. We never ran out of PPE in Northampton General. But there were times where it was all a bit dodgy, but that was the same across the country. And luckily I stayed healthy for the most part. What happens if an entire hospital ward has to isolate? So this is a really good question. If we were to go back to the start of the pandemic, so we were following government advice, and that included stuff about self-isolation. I don't know if you can hear my dog in the background. He's just woken up, so you might hear him whining a little bit. But if we have to isolate an entire ward, then signs are put up on the doors leading to the ward, and staff are made aware that those patients are having to isolate. But there are protocols for all communicable diseases, because even before COVID, you'd have norovirus outbreaks in hospitals, and so wards would have to be isolated as a result. So we are well equipped for that sort of thing. Swine flu, that's another one as well. Has your hospital been coping with the backlog of patients with planned surgeries now that restrictions have started to relax? I don't have the answer to that question, because I work in the emergency department, so we don't deal with surgeries. But yes, there is a backlog of surgeries, and it is just about getting through them as quickly as they can. And that is, I feel for the surgeons and the theatre staff doing as much as they can as quickly as they can. They're doing a good job, they're doing the best that they can, but it's a shame because there is a huge backlog. Was there a lot of ethical issues, like was higher priority given to certain patients, COVID patient over cancer patient? So cancer patients, so keep in mind that I was just dealing with the medical side. The operation side, emergency operations were carrying on. Sorry, he'll stop barking in a minute. It's probably because he can hear me talking. But COVID patients did get priority. If you had cancer and caught COVID, then a lot of decisions had to be made about what was going to happen. Some people, for religious reasons, may not have wanted to shave their facial hair off. Yes, that's absolutely right. There were alternatives. So we were not made to shave our facial hair off. For people who didn't need to have facial hair, so whether it's if they had it for cultural or religious reasons, they were allowed to keep it, and there were alternative arrangements made. People who didn't have to have facial hair or didn't need to for cultural or religious reasons where we were told to shave our facial hair. In hospitals like Leicester Royal Infirmary, where it's a big hospital, they've got a lot more money, there are a lot more hoods, so I could technically grow my facial hair back. I choose not to because I'm optimistic, and I plan on growing it back when the pandemic ends. Why can't family members meet patients in ward but by keeping a 2-meter distance? So hospitals are riddled with COVID, I think is the nicest way of putting it. So you got to remember that patients are not isolated in a bed space. There are curtains, but even though a family member may be safely distant from their loved one, COVID is in the air, it's on the walls, it's on the floor, it's all over the place, and so it is a risk. And also, if a family member is asymptomatic and brings in COVID to a patient who may not have COVID, then we have a bit of a problem. Did you have to employ more janitors? I don't know. So we don't call them janitors in this country, we call them domestics. And I don't know. I don't know the answer to that question, actually. What was it like being a point of care doctor with conspiracies of COVID spreading around in your aunties and mums WhatsApp room? Yeah. So conspiracies were a real, they were tiring to have to deal with. So I actually know some people who don't believe in COVID, and I just couldn't speak to them, and I still can't really speak to them. It's just, for me, it was a bit disrespectful to all the people who have caught COVID, all the people who have died from COVID, all the people who have recovered from COVID, and I can tell you now, a lot of them are not going to be the same ever again. And also all the health staff who work tirelessly. I think it's really disrespectful for conspiracy theorists. And I think mainstream media is mainstream because it's had a lot of stuff looked into. So you can say, oh, it's mainstream, they push it in your face, all these journals, they're not true, etc. They're mainstream journals because they've rigorously looked at things, so they are reputable. So yeah, conspiracies were tiring. How do you try to maintain a work-life balance whilst working in emergency medicine? So luckily in Leicester, the emergency department is actually really good at making sure we get our time and a decent work-life balance. Not always perfect, but we signed up for this sort of job, and we know that the work's can be intense. My days off, I make sure that I exercise, I make sure I watch TV, I make sure I put time aside for myself, and I look after my dog as well, who I did get during the lockdown. And having a dog actually helps a lot because you've always got someone who's excited for you when you come home, and we love playing with him. So how did you and your family deal with your constant changes of role? Well, I mean, for me, it wasn't a massive change. So being redeployed was I knew what I was doing in ITU, it was quite nice. And then I was always going to be progressing to be an emergency medicine registrar anyway. So that was always going to happen. So I was just preparing for that role anyway. Family, on the other hand, when I was redeployed, I didn't feel it was safe for me to see my parents because my parents are quite old. So I didn't see my parents for a very long time. I didn't see my sister as well for a very long time. And even now, sometimes I'm a bit apprehensive about seeing them. How many patients did 6 people take care of? So you mean when I was on ITU? So we would look after, what did we look after in the end? There was about 30 or 40, what was it? Was it 8? There's about 30 patients at most that are on ventilators, at most. That was in Northampton. But in places like Leicester, where they're bigger intensive care units, you'd be looking after a lot more. Birmingham QE, they have a hell of a lot of patients that they were looking after that only a few would look after. How many times did you feel like quitting a job during the pandemic? I didn't ever feel like quitting it. And I think it's because we really got on well as a team in when I was redeployed. There were times when it got tough in A&E, but with the vaccine coming at the right time, you always felt optimistic about the whole thing. And even now, I still try and keep a bit of optimism. So I'm quite a positive person about the whole thing. There were people that did quit their jobs, and there were people that left. And I've got to say that's leaving and quitting. It's not a sign of weakness. It's actually a sign of strength. It just shows that you've realised your limitation and actually you're better suited for something else, or you're protecting yourself, preventing yourself going through all the difficulties, which is a very strong move. And I do have a lot of respect for them. Did masks affect physical health, for example, respiratory problems? No, masks don't cause any respiratory problems. I don't have asthma, and some people can get allergic asthma, in which case sometimes the mask fibers can be breathed in. But we have people who we work with who have asthma and they wear the masks without complaining at all. How do you have to deal with difficult decisions, especially during the pandemic? Yeah, it was tough. Sometimes, like I say, sometimes you realise that you are the last face that this patient could ever see. That was quite difficult to deal with. And, you know, some patients that wake up, you're the only person that they can interact with because the family members can't come in. Out of interest, how was your ITU able to make use of the My ICU voice app? If so, how? So the ITU that I worked on, no, we didn't have that. We did do video calls. A local company actually donated a load of tablets to the unit so that we could do lots of calls for families. How is COVID in hospitals now? So it is rising. There's been a sharp rise recently. I was in last week on a stretch of nights and there was a rise. It's not like it was during winter, but we're prepared for it to get like that if it does get like that. How has it changed me as a person being on the front line in the pandemic? It's probably made me a bit, I don't know, actually, I'm not really sure. I think the best person to answer that question is someone who saw me before the pandemic and hasn't seen me since. But I like to think I'm a bit more calm about things, and I value my free time a lot more. I try and take on less things in my free time as well. Did physician associates play a vital? Yes, they did. They really did. PAs were absolutely fantastic because PAs, they often stayed within their teams, and because people were being redeployed to teams, PAs became a fountain of knowledge. They were incredibly helpful to help other doctors and nurses find their feet in those areas. And they also got redeployed as well. So they were brilliant. They really were brilliant. Was support available for NHS workers going through psychological trauma? So there is now. It became a bit of a problem earlier on, especially the winter wave, but there is now. So where I work, there is actually a team called the Wellbeing Team that have regular chats with all of us, and I actually find them really useful. So there is now, yeah. How scared were you for your own life? I was scared, but at the same time, you can only really, if you're gonna work in that kind of environment, you're working on the front line, aren't you? So if you're gonna go to work in fear of your own health every day, it's going to be a pretty miserable day. So I just tried to put it to the back of my mind and not think about it, and just take things as they came. So every time I had to self-isolate because I started getting symptoms, I tried to take it day by day and think, right, today I'm okay. I'm okay. If I need to go into hospital, I need to go into hospital. Don't think, 100 miles ahead of yourself. Just think right now. Right now, I'm okay. And yeah, I did have symptoms. I had a cough. I had fevers and stuff. And luckily, I tested negative each time. But there's always that worry. And I'm fully vaccinated as well. It was never hard to maintain professionalism. It sometimes can get difficult when you get people who you're diagnosed with COVID in and they don't believe you because they don't believe in COVID. But you got to remember, everyone is different. And for you, it may be your 20th interaction for the day, but for them, it's their first interaction for the day. And you don't want to sever the relationship between them and the NHS. So we tried to maintain professionalism as much as possible. And it wasn't as difficult as you think because everyone supports each other in the NHS. What else? I've answered quite a few of these already. There's sort of rewordings of other questions. My mum works in a hospital and she says every day that passes, the number of patients in ICU increases. Is this true in your hospital? Do you think we're slowly going back into lockdown high cases? That's a good question. Yes, so numbers are increasing, and I'm hopeful that we don't go back into lockdown. That's the way I'll answer that question. But realistically, it's possible, isn't it? How long is my annual leave? I go back to work next week on Monday. Do you think the right decision has been made with the easing of lockdown rules, or do you think it was too early to ease the rules? I think that's more a question for someone higher up than me. You know, I think it's a bit odd that July 19th wasn't delayed a bit further because cases were going up. I think that the last lockdown was very well handled by being so severe and being for such a long time as well, to allow the vaccine to take hold as well. But I think it was odd that we were brought out of lockdown despite cases going back up to 50,000 a day. That was a bit odd. But we'll see what happens. It could be fine. If you go back in time and pick another course than medicine in uni, would you do it? No, I would. If I were to go back in time now, knowing full well that when I get to 2021, I'll be dealing with the pandemic, I would still choose to do medicine. And I'd imagine if I was a nurse, I would still choose to do nursing. If I was a midwife, I would still choose to do midwife. Because one thing that never fails in the NHS is that sense of teamwork, that sense of camaraderie with your fellow healthcare staff. And that I feel, I don't know, I feel that is unique to the NHS. Yes. How did you feel? How did you reflect on the past 18 months? Did you sit down and write something, or was it just integrated into work? A bit of both, actually. So I tried kind of like doing a little, not like a diary, I suppose it was a diary. Every month I'd do a little entry on a Word document and just so I can look back on it. I stopped doing that after a while, and I just chat with my partner about things and chat with my parents on the phone as well about things. And that helped quite a lot. Talking about stuff helped me. Other than COVID patients, what were the most common type problems people came in the department with during the pandemic? So people come in due to sepsis, that could be chest infections or water infections, skin infections, joint infections, meningitis, and so on. Get a lot of elderly people falling, breaking their hips. You get, especially now with the lockdowns easing, the gangs are now mixing quite a lot. So we're getting a lot of gang-related violence. We get all sorts really in A&E. The best way that someone's described emergency medicine to me before I applied for it was, we are the best 20 minutes of every specialty. And I quite like the way we look at it that way. What else have we got? What's the difference between biggest difference between A&E and intensive care? Intensive care, so A&E is we start things in A&E, but intensive care continues the treatment. And a lot of the intensive treatments are actually continued or started up in intensive care. Our knowledge is quite similar, but they are more long-term intensive care, whereas we are just the first hour or so before they get moved to intensive care. So we think quicker, and we manage high pressure situations differently, and in some cases better. But they have to deal about the top end of medicine all the time, whereas we only have to think about it for a short period of time. What's the biggest and most important advice you would give any medical student? Medical student, well, I'd give the same advice to medical students as I would for people wanting to apply for medicine. Just make sure you know what you're getting yourself in for, and stick at it as well. It's worth it. I really enjoy it. A lot of people don't, but I think a lot of them didn't realise what they were getting themselves in for. But stick at it, because it'll be worth it in the end. What was the best part of medical school? Honestly, it was actually the elective. I went abroad. A lot of electives were cancelled during the pandemic, though. I don't know what the situation is now, but that for me was the best part. What were the other specialties you were interested in before joining A&E? So I was interested in a lot of specialties. So when I came into med school, I wanted to be a surgeon. That's all I wanted to do, surgery. I wanted to be an orthopedic surgeon, actually. Then I did orthopedics as my first clinical attachment, and it was so much fun. Then I realised that you're only dealing with broken bones. That's how I thought in my simple mind, and I just didn't really want to. You do get to cure a patient of their problem, which is unique to orthopedics. The the novelty of surgery kind of wore off on after a while. And I really enjoyed the more critical stuff, the emergency stuff. And then I thought, oh, there is a career in this, so I could do that. And I decided on emergency medicine when I was a fourth year medical student. Would you consider the NHS really good in terms of jobs as none remains unemployed? Yeah, I think the NHS is pretty good in terms of jobs. As a doctor, so I'd say about 99% of people are guaranteed a job when they graduate from medical school. It's not so easy to get a training post in your specialty though, because there's quite a lot of competition. So you get a lot of people wanting to be cardiologists and end up being something else. But I think it's pretty good for jobs. Right, I'm very aware that it is now 3:10. Do I have time to answer other questions, or do you want me to stop there? Or do I just carry on? Because is the next session in a different link or something? Don't know. I'll keep going until I'm told to stop then.
Sorry, Nav, I am here.
Oh.
Yeah, so they've you will have noticed that we've lost kind of half participants. We have their group session, which has started sort of 5 minutes ago or so. So I think if you perhaps want to maybe pick out a couple of final questions, we'll finish off with a couple of final ones. Thank you.
Yeah. So a good question here. How was it like dealing with death as a more heightened event due to the pandemic? It was actually quite tough because so in intensive care, people do die quite often there because they are already very, very unstable when they go to intensive care. But during the pandemic, they were dying more often. And that was quite difficult to have to ring up families and tell them, and then have, you couldn't bring them in and speak to them, put your hand on their hand or put your hand on their shoulder, give them a cup of tea. You couldn't do that anymore. So you would have to listen to them crying, pleading with God over the phone. And it was really difficult because we felt terrible. We wanted to give them a hug, but we couldn't because we were at the other end of the phone. So that was quite tough. And in A&E, we do get death there as well, and that can be quite difficult to deal with. But it is part of the job. I don't know many specialties that don't deal with death in medicine. Some specialties deal with it more often than others. But certainly for my partner, dealing with death was very difficult. And so she's chosen her specialty based on less deaths in that specialty. And that helped her realize what she wanted to do. How did you deal with all the pressure, stress, and possible guilt with being on the front line? So I've talked about the pressure and stress. I'm not sure what you mean about the guilt on being on the front line. So I'm not really able to answer that, sorry. What else? I'll go one more question. Let's see. What kind of uncertainties did you face? I like that question. So we faced the same uncertainties that everyone in the public faced. We didn't know what this virus was going to be like at the start. We didn't know if you caught it, were you going to die? We still don't know the long-term effects of this virus for people who have recovered. And also because we saw what can happen to people. So the people who survive from intensive care, they are incredibly frail when they get discharged. So to give you an idea, there was a guy that we admitted to intensive care. He stayed in intensive care on a ventilator for about 50 days, which is a really, really long time. He was well built, maybe a little bit overweight, only a little bit when he came in. He was skin and bone when he left. I remember shaking his hand because we had all the PPE on, so we could shake their hands. And I remember I could see every single tendon and bone in his hand. And he didn't have the strength to walk to the car. They released a video because he allowed it to be released to the media. And he could only walk a short distance before he had to be pushed in a wheelchair to the car because he was just literally a shell of the man he once was. And we don't know the long-term effects of this virus. So there's still uncertainties around that. But we faced the same uncertainties as everyone did. The only difference was we saw what could happen to you. And we still face the same uncertainties about, are we coming out of lockdown? Can we plan holidays? We don't know. So I haven't had a holiday for a long time. So I've decided to space my annual leave out for the next academic year from August to August, instead of taking a big clump, because I just don't know what's going to happen. Like, can I go abroad? If I book a holiday, will I have to cancel it? So I just thought I'll wait until there's a bit more stability. Yeah, I'll leave it there. I saw the question about the Euros, but I'll type an answer to that one. But otherwise, please take note of what slide is on the screen, because I could really appreciate your help with this study. Like I say, every single one of you gets a £10 Amazon voucher. If a lot of you sign up for it, we will do an additional date, and that way we can still get you your money, and it means more data for me to collect. It's just an informal chat, virtually. You don't have to have your cameras on, and it's really a chat amongst yourselves, and I ask a few questions here and there. It's a lot of fun. You'll gain a lot of information as well. If you're wanting to do medicine or any healthcare related degree, then this sort of thing is for you, because we find that a lot of people benefit from it. So please do either complete that short form or email that email address for more information. The first, or one of the focus groups is tomorrow, but we can organise another one if there's a lot of you.
Perfect. Thank you so much, Navin, for your time, your expertise, and your knowledge today. I think it's fair to say the students got an awful lot out of your session. If you want to send me your slide, we can pop it into our roundup email at the end of the day that all students will get access to as well. So I know a few are asking for the link and things. So send it over to me and I will sort that out.
Shall do. Thank you.